Welcome back. Happy Thursday, beautiful people around the world. It is episode 134 of Two Chaps, Many Cultures. Welcome along, and on a very important topic today, relevant at all times, but relevant even more so now in times of medical maladies and impacting so many of our lives, and that is cultural competence in the medical field. Very, very important. We're going to talk about that with a very, very special guest. Hello and welcome back to the show about the culture of business and the business of culture. Welcome, pal. How are you, mate? Are you feeling well? Are you well? Are you healthy?
Yes, I am. Thankfully, I am. And thanks for asking. I hope you are too, because it's these days hard to know.
It is difficult. Yes, I am absolutely very healthy, very blessed, very healthy, and very well. And we hope that the things that have this particularly this virus, but other things, of course, that are going on in the world now that we're on the other side of the recovery curve. And but as I mentioned in the intro, we are here to talk with a special guest today about the importance of cultural competence in healthcare, because this is something that I think impacts people not only here in the US where we are, but also anywhere around the world. And I've always wanted to do this. I want to say, is there a doctor in the house?
Yes, there is. And her name is Stacie Walton, MD. Welcome to the program, Stacie.
Thank you. Thank you for having me.
It's a pleasure. It's a pleasure. I'm actually super curious about this episode today, because this is a topic that I've been reading about and following, yet I am by no stretch of the imagination am I an expert in the medical arena, and especially as it relates to being culturally competent in that field. So I'm happy that you're taking time for us today.
Well, I hope, Christian, by the time we're done talking, that you realize that you actually have a lot of expertise in the culturally competent world of medicine.
Okay.
So I'm going to convince you of that.
Good. I like to be convinced of something that I apparently already have.
Yeah.
I mean, and it's kind of white guys of certain age, you know, we really need our egos built up. I mean, you know,
if there isn't enough white guys with big egos around yet. Yep. Inflated a little. Yeah.
Well, it really speaks to how I, as a physician, am in the intercultural world. And yeah.
No, that's great. Well, tell us about that. I mean, you could probably go through, and you've obviously gone through the education, and I mean, look, anybody that knows a doctor and knows what you have to go through in your education, and you're just experienced it to get to where you are. It's an accomplishment of monumental proportions. But then to add to it, of course, then you have this wonderful passion for then building into that. Now, what can I do in addition to all the great work that you do as far as like the cultural competence side of it? So, talk us through that kind of process and where that got you.
It was pretty much a natural progression, because I started off in college majoring in cultural anthropology. And with the intention of going to medical school, changing my mind back and forth, eventually going to medical school. But I brought that perspective, the perspective of the cultural anthropologist, with me as I continued my education. And it was obvious from week one of medical school that there were some inherent structural issues in medical education, as well as how medical education was taught, that we were ignoring some of those cross-cultural communication issues. So that became apparent to me early on. And then I had an experience in 1997 when my daughter was born of what I realize now. I didn't realize it at the time, but I had this experience of some unconscious bias, implicit bias bubbling up at the moment of her birth. Mm-hmm. Her dad is African-American, I'm African-American, and when my daughter was born, she was born with blonde hair, blue eyes, and white skin. Mm-hmm. And instead of having that absolute rapture that I'd had with my son a few years earlier, I completely shut down. Like, the color of her skin threw me for a loop, and I was paralyzed in fear. Mm-hmm. What did it mean? Why did this happen? And to make a long story short, because I could go on the whole hour talking about that experience, I did what nerdy people do. I went to explore that reaction. I knew it wasn't right. I knew it would create problems with my relationship with my daughter moving forward if I didn't get to the root cause of that reaction. And it led me to the National Multicultural Institute in Washington, D.C. And after a couple workshops around race and culture, I found myself in a workshop around cultural competence. And in that, I'm a physician at this point, but in that process, I realized, oh my gosh, this was the link. Basically, Milton Bennett's model on intercultural sensitivity was my link to understanding what was missing in healthcare education, medical education. So I went there for myself to understand these concepts even more than what I had gathered in my undergraduate education. But I also had this remarkable insight related to medical education. So I went back to my institution, started incorporating the model to work in medical education. There are lots of models to help with understanding how to be more culturally competent in medicine. But the one, of course, that resonated with me was this model because, you know, it's a model that uses the language of anthropologists, right? Ethnocentricity, ethnorelativity. It also brings in concepts in the psychological field, right? And so it was a model that worked for me. And as I pushed forward medical education and started having these conversations with students and residents, I would use the model. How would I use the model? I'd use the model in saying, you know, when we approach, how do I say this? When we look at cultural differences, and this, Christian, is where I think you're already an expert. When we look at cultural differences, just like we look at nation differences, right? It's the same process. We can be in an ethnocentric kind of perspective as we're abutting that country that we go to live in. We can stay in that perspective where we're holding on to denial and defensiveness and minimization, or we can have the perspective where we're accepting and integrating and adapting. And that's why I say, as an interculturalist, it's the same thing in medicine. So maybe we're not talking about two different countries. We're talking about two different genders that might be relative to a medical decision that you're making. Or, of course, my subspecialty, because it's very personal to me, is in the last few years, I've been really focusing on race and racism in medicine.
There's two, and sorry if I'm butting in here, but there's two loops that I would like for you to close for our audience. So there's, and for me, so there's this first loop that you opened about recognizing biases in the medical arena. I would like to hear an example or two of how you became aware of that. And then obviously the nerd that I am wants to know what's the biological explanation for the way your daughter looks like? Is there an easy explanation that's easy to explain?
Well, usually, okay, let's start with my daughter, because that's, people are probably at the edge of their seat on that one.
I am. I'm standing up.
So we have to look at U.S. history. 400 years of U.S. history. And we have to open a very difficult door for many people. And we have to have a conversation about slavery.
Right.
So if we look at slave history, we know that there were part of the ability to prop up that industry was the birth of, how do I say? Trying to be so diplomatic, I should just throw that out the window.
Lay it on us.
The bottom line is slaveholders were dependent on numbers, masses of people. Their economy was dependent on numbers. And so how can we increase the number of slaves that we own as laws began changing, specifically from Europe and England, where the international slave trade was
dwindling
and becoming illegal? How do we keep those numbers up? Well, it's in having more babies. And how is that done?
We rape female slaves, right?
Yeah.
Basically.
And very difficult history, but that's the reality.
Yeah.
And on both sides of my family and the father of my children's family, we have that enslaved history, right? And so if I had like the intellectual conversation with family members, with my husband at the time, like if I had asked, I wonder what our daughter's going to look like, we would have had that conversation about, and this is true for most African-American families here in the U.S. When you have that conversation, it is a question mark. Is the skin going to be dark? Is it going to be light? Is the child going to look like Uncle Harry? Is the child going to look like Grandma? Because for most African-American families, if you go to a family reunion, you will see every shade of black, right? Yes. Someone who is so light-skinned that they could, walk in the world and people would presume that they are white, and just the opposite.
Right.
That was true for my family. If we had that conversation, I would have anticipated the possibility that my daughter wouldn't be, cocoa brown like my son. But what happened was that bias, right, of what I expected bubbled up. I had to grieve what I had expected. And as we know, there are some harms that if we do not heal from, they continue in our life to cause harm, right? And the last thing that I wanted was that particular bias for myself to have any effect on my daughter.
Right.
Right. So I needed to figure out how I could embrace her holistically, 100%. And that's why I went on that journey. And then, I always tell her was a blessing in disguise, because it opened this door for my professional career that's just been amazing ever since.
So there was nobody preparing you for the possibility of having a child that doesn't look like her mom or her dad.
It was never even the part of the issue that I had some shame around was I prided myself in having such a multicultural extended family, and I grew up in a family with lots of tolerance of difference. So I didn't grow up in a family that degraded different cultures or different ethnicities, or there was just a lot of tolerance for difference in my family. So I was very surprised at my reaction. If someone had asked me ahead of time, I would have said it wouldn't matter. It doesn't matter. What is skin color? It's just something that gives us a little more spice in life. It has absolutely no meaning, really. I mean, scientifically has no meaning. In real life, of course, I always say, when I'm talking about race, race is a social construct that's not valid. It's not scientific. It was invented at a time where it was used to exploit people around the world. And then in the U.S., in our U.S. history, we've used race to prop up an industry, to divide people. Do we have to talk? Let's not talk politics.
Are you speaking in the past tense, Stacie? I think we should remain in the present tense.
I think it was 7 days ago. But what was the other question, Christian?
The other question brings us back to away from your personal experience, maybe to a more general view of the medical field. How culturally competent is the medical field? How prepared are caregivers, hospitals, nurses, doctors, doctors' assistants? How well trained are they to deal with different cultures in their facilities and responding to different needs and different views on being sick or being afraid or whatever emotions come up in those fields?
I would also ask, just to build on that question, if I can.
Yes, please.
Just to identify for us where you think that information is introduced to doctors when they're going through their education. Is it in the education process, or is it assumed and left up to them to learn for themselves on the job, if at all? That's the important thing, right?
So I feel like I have 4 questions in front of me.
Sure. Yeah.
But I'm going to start with a little bit of a historical question, and that is, I believe it was in 2001. The New England Journal of Medicine published in their peer-reviewed journal, like this is the Mecca journal for physicians, an article out of Harvard that revealed in the research that physicians had unconscious bias. So we're talking almost the year 2000. Well, we are talking about the year 2000. And physicians were being told, guess what, guys? You're just like the rest of us. You have unconscious bias. Psychologists have been talking about this for decades. The business world is already involved in that process of looking at bias in business relationships. Catch up. Mm-hmm. So what happened in that research, it showed that physicians had no problems diagnosing a cardiac problem in a group of patients. But when it came to their treatment recommendations, the recommendations were categorized, unbeknownst to them, they're blinded to this study, that they were making different decisions depending on which group you fell into. If you were white males, you got, AAA care. And the contrast, if you were Black females, you pretty much were told, well, go home and take an aspirin. I'm exaggerating a little bit, but there was a clear difference between those two groups of people. And there was a gradient, whether you were white male, Black male, white female, Black female.
Based on the assumption that there is a socioeconomic divide between these patient groups and they won't be able to afford a different form of treatment? Or what do you think this is based on, this rationale?
The conclusion of the article was, the question became, could this be related to unconscious bias? Mm-hmm. Biases that you're not aware of? Yes. Could those biases be socioeconomic? Absolutely. Could those biases be strictly around race? Mm-hmm. Right? Could those biases be built in around... It gets very deep, but That was the first time that question ever was posed to physicians. There was an incredible amount of pushback to that article around the data, around how the data was analyzed. You know, this is the peer-reviewed New England Journal of Medicine. And most importantly, cardiologists weighed in and said, you know what? It was the Black females who got the best care, because that triple air care actually put white men at risk for complications. That's a whole nother conversation. But the point is, fast forward 20 years. In the last 20 years, now we have thousands and thousands of research studies pointing towards unconscious bias, implicit bias, unequal care, different. And so the example I'd like to give you that relates back to your question about the brain, right? Our brains are wired in such a way that survival is number one. And part of that survival, and I'm simplifying it a lot, and I apologize to any neuroscientists that are in the audience, but my decision-making is related to whether or not, Brett, I've decided you're part of my tribe or not, whether you're an other or whether you belong to me. My level of empathy is related to whether you belong to me or not. So my decision-making, unconscious decision-making, is related to whether I other you or you belong to me. So imagine if and here's the example I give. I had a 7-year-old little boy who came to see me with a severe stomach ache. And even my medical assistant, who's brilliant, Daisy, I've got to give her a little shout out. Daisy.
Shout out to Daisy.
Shout out to Daisy. She said to me, Dr. Walton, I'm going to have you see him first. He's really, really sick. He has a terrible stomach ache. And any physician in that moment hears severe stomach ache. They begin their differential diagnosis in their mind. What could this be? They place the most severe and life-threatening problem at the top. So what did I think? Oh, could this be appendicitis, an inflammation of a part of the GI tract that the cure is surgery, removing that inflamed, infected piece of intestine?
Been there, done that.
Oh, so you know how painful it can be. And, you know, there were other things on my list. Could it be stomach flu? Could it be food poisoning? But when the patient walked into the exam room, even before I examined him, by the extremis on his face, by the way that he was shuffling in, his inability to get up on the exam table, and then when I examined him where his pain was located, it was a slam dunk diagnosis for me. Now, granted, this was a family that I had known for a few years. The mother and I got along beautifully. The child was adorable. They were African American. They were African American. I just throw that out as that's important to the story. And that was my diagnosis. I sent them to the emergency room expecting that child to get surgery within hours. But what happened was later that evening before I left the office, I said, let me check on him. You know, went back into my computer, into my electronic medical record, and he'd been discharged from the emergency room with the diagnosis of the stomach flu. I called the mom. I was sure of my diagnosis. You know, I was shocked at theirs. And she said to me, yeah, they saw him. It was very short. It was very curt. I felt like the doctor wasn't listening to the story. And the doctor was convinced it was just the stomach flu, and they sent us home. And I said, you've got to go back. And she says, there's no way that I'm going back there. I'll come back to you, but I'm not going back there. And I believe that this is an example of how I'm making some assumptions that this physician, who was just as well trained as I was, othered this child and his family, probably subconsciously, and didn't see what I saw.
What was the essential diagnosis? And was it appendicitis? Did he have to have it removed?
Yes. Okay. It was appendicitis the moment I saw him, and 2 days later he returns with me making phone calls to higher authorities above the emergency room doctor's head. Basically, I called him up and I said, "Look, this is what it is. Get him an imaging study. I'm going to talk to your chief if you don't." That's what happened. And at this point, the appendix was burst. It was ruptured.
Oh, boy.
It was a more serious disease. So you can see how we can get the kinds of statistics that we get.
Right. So bias leads to malpractice in this case.
Bias leads to poor decision making. There's been a lot in the news recently. There was a recent article that said that black pediatric death is less likely to happen if your doctor is also black.
Mm-hmm.
I know my colleagues, my white colleagues, phenomenal pediatricians. When they hear that statistic, they're devastated. Black physicians are devastated. Oh my gosh, because I can't take care of every black child that's on the planet.
Mm.
But my white pediatric physicians are devastated by that statistic as well. Because the intention for most physicians, granted, you're going to have, in any profession, you're going to have folks who have explicit, conscious prejudices and stereotypes,
right,
and are unapologetic in behaving inappropriately.
Right.
But that is definitely the rare healthcare provider who feels that way.
In a field where you have such a thorough academic training to actually practice your expertise, I think it shatters the self-image of any doctor, regardless of their ethnicity, to have their objectivity challenged, right? Because that's what you're trained to do as a scientist. You're being as objective as possible. You're ruling out your gut response. You're double, triple, quadruple checking the facts and finding the best scientific answer, and then being told, well, but still you have this unconscious bias. You have a fault switch built in that you weren't aware of. That's got to be rattling at your self-image as a physician, right?
It definitely is, and that's why there was so much pushback on that original article. And I would argue as well, that's why we haven't made very much progress in 20 years.
Oh, wow.
Yeah.
Right. That level of, when you think about cultural competence and you get, you have some information coming at you, where do you go when it is a difficult thing to hear? Denial, defense.
Mm-hmm.
Right? I'm going to go to that place that's comfortable. This could not be true. When you look at medical education, one of the things that's beautiful about this country, and that one of the things that makes it more difficult, is that we allow institutions to set their own course. So the regulatory bodies in medical education, residency education have all come out with very strong policy statements about medical schools and residency programs adopting curricula that address culture, cultural competence, cultural humility, cultural proficiency, that look at issues around diversity, equity, inclusion. But how you interpret that policy, that one line in a document, is night and day. I'll give you a couple examples. If you look at the cultural competency, cultural equity program at the University of Hawaii Medical School, it starts in day one. It starts with cultural immersion with quote unquote native people. Those students their curriculum is totally integrated with their clinical experiences across cultural differences.
Mm-hmm.
They have an international experience built in, right?
Mm-hmm.
And so you compare that to a medical school that is fulfilling that responsibility with a lunchtime talk 3 times a year.
Yeah.
Right.
There's that. And to this day, there's that, the discrepancy is that large. You have some institutions around the country, UCSF, Harvard, I could make lists that have a department, an institute dedicated to exploring health disparities and social determinants of health and integrating what we know into the education of their medical students and their residents.
Something
But
that
there's such an inequality, I guess, or difference depending on the medical school.
Yeah.
But I will say, younger physicians, these recommendations didn't exist when I went to medical school, and now they are policy. So we're making progress.
Slow, but we are.
We are making progress, but it's slow. You know, one of the things is you have to name things before you can move forward. And so the naming, 20 years ago when I was teaching cultural competence, and I remember being at the National Multicultural Institute, the facilitators were really clear about, you know, you want to be careful because if you mention this, you'll turn everybody off. If you say the R word, race, you're going to turn everyone off. If you say the S word, sexism, you're going to turn everybody off. We don't want to do that. We want to we want them to hear the concepts of competency, but we have to be careful how we do it. You know, now when I talk about
to tiptoe around it, was that helpful, or would it be more goal oriented to actually address the issues as they are?
Well, if you've read the work of Robin DiAngelo, a sociologist who wrote the book White Fragility.
Yes.
Even today, we have to, as cultural competence or cultural humility practitioners, we have to sometimes read our audience. I think we've just experienced an explosion in this last year, 2020, of people wanting to have more of a conversation specifically around race, that the kinds of things that were taboo to bring up 20 years ago, 10 years ago, we're talking about them openly. I talk about race and white supremacy. Do you think I would have talked about race and white supremacy in 2000? Well, the answer is
this is where my perspective battles that of many U.S. Americans, because as a European, and when I came to the United States for the first time, it was in the 1980s. I was a teenager, and I addressed these issues with the words that I had available in my vocabulary at that time. And looking back now, I know I must have stepped on a lot of people's toes and ruffled a lot of feathers. But for me, my upbringing had taught me, my culture had taught me that it was acceptable and familiar to address even the most painful conversation topics head on. Otherwise, we would simply be poking around in the dark and not making any progress. At least that was my normal, right? So if the way you're framing it very diplomatically, Stacie, I see what the context of all this is. Even after all these years of living in the United States as an immigrant, that's something that I still struggle with, the inability to face up to uncomfortable truths. And that, I think, as long, and you said this beautifully in the beginning, if we don't heal from a pain, or if we don't thoroughly recover from a trauma, it will continue to haunt us. and this trauma of inequality and many other words we can give it, the unequalness, the injustice in U.S. society has been perpetuated, in my opinion, because the old pain was never allowed to heal. The pus is still oozing from that wound that hasn't healed.
It's like our president, our newly elected president, said 1 week ago. He, in reference to what happened in D.C., he and many prominent and high elected officials said, "This is not us."
Well, it is us,
right? This is not us. The insurgents, attacking the Capitol, the violence, whatever that was going on. The response by our leaders was, "This is not us." But that's the denial.
Yeah, the uncomfortable truth is you saw it on TV. It is us.
It's the uncomfortable truth that this is us. And until we're willing, and there's been some brilliant professors who've been having this conversation for a long time. This is not a unique concept for me, but I will reiterate it. This is us. And when we're ready to confront and discuss it, that's when we can get to the healing. That's when we can move towards next steps, which brings me to the brilliant work of two interculturalists that I adore, Casey and Robinson, who wrote the book, Neuroscience of Inclusion. And they're both interculturalists, and probably have met them. And they remind us that we are in, when we are in certain brain states, and this work comes out of a lot of research out of Harvard, we are more likely to be operating from, thinking from a place of unconscious decision-making. So if we're in fear, we're less likely to be thinking creatively, thoughtfully. We're using our unconscious biases to drive behavior. We're less aware of our surroundings. And that's what I saw on Wednesday. Right. I saw thousands of people who were operating from their lower brain state, therefore were making really, really poor decisions and weren't aware.
I'm gonna oversimplify what you said just because I like simple. When the emotions are high, intelligence tends to be low, and vice versa, right?
For me, in my humble opinion, it's a little too oversimplified in that only because there are some emotions that if you're in more of a higher brain state, you can access them in such a way that they support and buttress your thinking and your awareness and your perception.
Thanks for clarifying.
But that's important. Emotions do affect how we're thinking. No question about that.
Right.
Yeah.
So this is a diagnosis. I mean, I'm watching you, I'm listening to you, and you have whenever I've had a really good doctor, it's been like you. It's been somebody who's, very deductively thinking. There's a lot of and my brain doesn't have that capacity. And I probably am more like on the other side of just reacting in emotion through unconscious bias, right? Mm-hmm. You have this so many different wonderful perspectives that lay at the very heart. I just want to go back also and ask you a quick question, if you can answer it quickly, just about that experience of then confronting the, let's call them the management of the people of that hospital you sent that little boy to. And, you from an outward perspective, it's not, I think it would be fair to say that not often that if most people would look at a black woman and not specifically assume that she could possibly even be a doctor, right? So there's that. And the other side of it is that you're a woman. And so I can see that maybe it wasn't true, but in that case, let's maybe suggest that there's a possibility that the management of that hospital may have been white and male, or And so that a bias of sexism, like you called it, and racism comes into play, even in how they respond. They're not then focused on the 7-year-old boy. They're focused on their own ego,
Yes.
right?
Yeah.
And that must be difficult to navigate. So I just think that I just wanted to say that, and I think that that comes back to, you know, the many people that kind of come to us, even in this field of work, that say, I think I've got a message to put out there. I think I've got some knowledge. I think I want to provide the people around me and the work and outside the work that I do with the resources, or at least access to the resources to make their own decisions. So that's important too. You've done some great work under the banner of being called like the diversity doc, right? I think that's fantastic, by the way. Very clever. But I mean, but it is a great, it's all about branding, right? It's a branding of yourself as somebody who comes from a great deal of experiential knowledge, scientific knowledge. So how are you putting that out there in the world? I think people really need to find that stuff, you know, even people like us that are not doctors.
Right.
Well, all of my business mentors say to me all the time that I am way too eclectic to be a business consultant. And that is,
that's an interesting,
you know, because
okay.
and I say that because right now, in terms of what I'm doing, I am running racial healing workshops. I am consulting a nonprofit to help them with their diversity issues, recruiting more diversity to their program. I am consulting a large national corporation who is embarking on, this is so amazing, a reparations project. And project's not the right word, but a reparations, I'm going to call it project, to actually dismantle some structural racism in corporations. So, I mean, I would say what I'm doing right now the most is, and because I've surrendered to what happened in 2020, this opportunity to support racial healing and supporting people having paradigm shifts in their worldview to become lifelong learners, lifelong committed to being lifelong, I guess, social justice warriors in making society a better place. So I am. Did that answer your question, Brent?
Yeah,
The kinds of things
absolutely.
I'm
I
doing?
mean, that's really I know that's what you're doing. I just wanted you to say it and put it out there because, you know, we hope to share this around to many, many different people. Yeah.
So if I were in a position where I could introduce you to leadership of a healthcare company that is operating a hospital or, I don't know, assisted living or multiple facilities, and they want to address that issue, how would I best introduce you to the administration or to the leadership of such an organization to facilitate the change that is required?
Well, can I also ask just on that, does it have to be a healthcare company? I mean, I think,
right.
you know, I think it applies. This is the connection, right? It is, I mean, really, I mean, we're in a country, I guess I always say that, you know, unlike where I come from, here, healthcare is a business. You know, it's a for profit, you know, so it is a business. So here you have, through an unfortunate set of circumstances, to be able to bring that skill set and apply it to a car company or a manufacturing company. Anyway, I don't want to throw you off the course with a very important question. I'm sorry. I keep doing this, don't I? I'm sorry.
I think for me, I am not your typical like diversity, equity, inclusion consultant. I'm not going into organizations and making a diagnosis on where they're at and where they need to be. I would say what I provide is a business or an organization, a nonprofit, a healthcare department that's already on the journey and have consciously said to themselves, how can we make this sustainable? What do we need to put in place that this isn't not a one and done workshop? What needs to happen so this truly becomes part of our company culture? That the embracing of and the appreciation of difference becomes celebratory, not a problem that needs to be managed. And how can we what can we add to the larger profile that's in place to make diversity, equity, and the sense of company inclusion like sustaining? And the way that I do that is I bring in a process called healing. I can change the words so that it doesn't sound so Birkenstock. Bring in a process that's been shown to be dynamic, appropriating Native American process, the peace circle, using this process of getting people together with some bit of ceremony, removing hierarchy almost completely in the process, setting up a system where groups of employees or groups of executives or groups of, a board get together on a regular basis, and we have brave conversations, difficult conversations, the important conversations in a safe, confidential, authentic place. We build community, and we solve problems, and we heal.
Nice.
Was that too philosophical?
Yeah.
No, that's
and then the result is trust. There is a trust, right? There's a trust at the end of the
And
I just want to jump in here before maybe you might be able to answer this question. Hi, Esther. How are you? Thanks for joining on Facebook. Esther's joining us there. The name of the book you mentioned before.
Actually, there were two books, right? You said Dr. D'Angelo. That would be Dr. Robin D'Angelo. The book is called White Fragility, widely discussed in the last 18 months, I would argue. But you mentioned another book, right?
Yes, I just happen to have it here.
Look at you. This is
Let me move my globe. Okay. All right. This is Mary Casey and Shannon Robinson.
Yeah. Shannon Murphy Robinson, a good friend.
Yes,
in
exactly.
the Theatre Network. Yeah.
Neuroscience of Inclusion, New Skills for New Times. And basically, it's a great book that explains the neuroscience as well as makes some really nice recommendations on how you can move personally and move an organization to be more inclusive. They've got one of the formulas that works. It's not the work that I do, but their work has influenced my thinking.
Nice. So Esther, I hope that answers your question. If there is another book that we mentioned and forgot to clarify, let us know in another comment. Otherwise, you got your reading cut out for you for the next couple of months. I don't know how fast of a reader you are.
Absolutely. Yeah. Thank you.
That's the one. Good.
Perfect.
Glad to help. Stacie, I have so many questions and we have so little time. I think we need to have you back here again because there's you tipped the domino in my head and they're all spinning and falling right now, and I know there's so much more to explore in this arena. I want to say personally thank you for trusting us as interculturalists with no medical background to be already competent in that arena. And to my saving grace, I did serve my country in the military because I had to, because back then Germany had a conscription army. And I chose to be a med tech and not one of those soldiers running around with a gun. I was one of the soldiers wearing white in in a hospital, basically. So that's my little bit of connection to your field. But I would argue that there is a lot of work to be done, especially in and around giving care for others, because that's where we as humans are most vulnerable, and that's where these conscious and more often than not unconscious biases are big obstacles to healing and big obstacles to giving the best possible care.
Yep, absolutely. Well, thank you, Stacie. Wonderful. Again, I'm just going to add, I can't add any more than that, just to say you have graced us with a great deal of information here today, but I think we're only scratching the surface of where it could go. And you're doing wonderful work. Thank you so much. And thank you. It's been a real honor to have you on the show. Thank you to those who joined us. Christine's here again too, as well as Esther and many others that have joined us. That is not the limit of you being able to comment. Of course, share this if you like this. Share this with your friends and family. Subscribe to the YouTube channels. Add your comments on the replays if you will. And please reach out to Stacie, the Diversity Doc. You will find her on all the wonderful channels around the place. In the meantime, this is Two Chaps, Many Cultures, episode 134 in the can. How do you say it? How do you say like a really full diagnosis and treatment is done, Stacie, in the medical field? What's a good terminology? Is there one that exists?
I don't know what you just asked me, Brett.
No, patient is charged, I guess.
I'm using a showbiz term because for some reason we think we're in showbiz here. That one's in the can, you know.
Yeah.
No, I put you on the spot, but thank you again.
Thank you.
We hope to see you again.
I want to say thank you very much for having me on. And if you truly want me to come back, the answer is yes, 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 because I am an educator.
Absolutely.
So thanks for having me.
And a very generous one at heart. That's right. Yeah. Hi, Bert. How are you? Thank you.
Excellent. Thank you, everybody. See you again. Two Chaps, Many Cultures tomorrow. Different time. Check your socials for the information. Ciao for now.
Bye-bye.